Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm speaking to the chair of the Royal College of GPs, Professor Kamila Hawthorne, ahead of the RCGP's annual conference in Newport in Wales, which starts on Thursday this week. GP Online is once again the media partner for the annual conference, and this is the first of 2 episodes that we'll be producing from the event this week. Kamila is coming to the end of her 3 years leading the college, and in this interview she reflects on the highs and lows of her time in the post. She talks about the experiences of dealing with multiple health secretaries and navigating the contentious issue of physician assistants in general practice. We also discuss the government's 10-year health plan and what it could mean for general practice, her fears about the future of the partnership model and what the RCGP wants to see in the new NHS workforce plan. And she explains why she believes there's still a bright future for general practice despite the challenges. You can catch up with all the latest news from the RCGP annual conference in Newport in Wales this week at GPonline.com/RCGP. This episode of Talking General Practice has been supported by Simprove. Based on an external survey of 432 healthcare professionals, Simprove was the #1 probiotic recommended by gastroenterologists, dietitians and GPs. The unique water-based solution delivers live bacteria to the colon and is proven in randomised controlled trials by leading institutions. 92% of people report a benefit within 12 weeks in real world. Healthcare professionals can trial Simprove for free. Visit professionals.simprove.com and sign up for a virtual meeting to hear more about the research behind Simprove and get your free 12-week pack. That's professionals.simprove.com. I'm delighted to be joined on the podcast now by the chair of the Royal College of GPs, Professor Kamila Hawthorne. Kamila has been chair of the college for almost 3 years, and we're speaking ahead of her last RCGP annual conference as chair. Thank you for coming on the podcast, Kamila. It's really good to have you back again.
It's a real pleasure, Emma, and lovely to see you again.
As I mentioned at the start there, you're coming to the end of your time as chair, 3 years. How would you sum up the last 3 years?
It's been the most amazing experience. I would never have known how amazing it was going to be beforehand, despite having been vice chair for Helen Stokes-Lampard and sort of watched her doing it. It's never quite the same as actually doing it yourself. There have been some really exciting times, and there have been some really difficult times and some very scary times. But I've met people I would never have met before, and I've been to places I would never have gone to before, usually with my mouth wide open in awe. And I've really enjoyed it. And I've also enjoyed bringing the voice of general practice, I hope, into the media and speaking for our members. You know, having been a GP for 37 years, it's very much ingrained in my whole body.
So what would you say has been the best bit? What have you enjoyed the most?
So it's really difficult to pick things out. I've enjoyed the annual conferences, the buzz, the ongoing narrative of developing relationships with health secretaries. There's been quite a narrative there with Wes Streeting. I don't know if people remember, but 2 years ago at the annual conference when we launched our RCGP manifesto, he greeted it with real negativity. And yet a year later, he was coming to the conference and being a very joyous part of it, very positive, constructive part of it. And then, of course, you know, we've had the 10-year health plan, which has put general practice right at the centre of the stage. All of that's been really quite exhilarating in itself, just watching that on. So it's not a single episode, it's more of a narrative, I suppose. The other thing that I have found really exciting was actually it takes ages being an influencer, but the really exciting announcement suddenly out of the blue by him up in Blackpool that they were going to revise the Cahill formula, something we'd been campaigning for a long time. And certainly in one of the practices I've worked in Butetown in Cardiff, I've absolutely seen how difficult it is for GPs working in deprived areas. The income just doesn't compare with the leafy suburbs. And I've seen young and altruistic and keen GPs come and go because the money was poor. So I'm really pleased with that. I've been watching the 7 steps that we put into the manifesto. 5 of them have now been accepted by the government, and they're coming out in one way or the other, including the revision of the Cahill formula. Also being able to bring the qualities of a GP to the work that the college does. At a college level, how do GPs behave? And we've had the launch of Jess's Rule. We've been working with her parents for the last 2 years slowly building a really good, constructive relationship, doing what we can to help people who are just terribly bereaved with the loss of their daughter and who want to make things better by not only providing them with the empathy and the personal condolences. We've also materially helped by producing an e-learning module on diagnosing cancer in young people with Jess's story at the front of it. I really recommend people to look at it. It's free. I'm sure it will touch your hearts. And that is just part of what we've done as a college, which is what we do as GPs every day with our patients. And then, of course, as chair of council, I have the privilege of choosing 4 strategic priorities at the beginning of the 3 years. And the work we've been doing on those priorities. So the first one was workforce and workload. You might say that's 2 in 1, but I've put them together. The second one was about the member value and how do we make this college more the professional home of its members. And we do seem to be succeeding there, slowly edging up in satisfaction. The third one was health inequalities, and the fourth and last one was sustainable healthcare, which I feel is everybody's business. And we started from a low baseline because we really knew very little about how one might do it as a GP, but we're doing pretty well on all of those. And again, a paper on that came to council last Friday, and it will be on our website for all members to have a look at if they want to.
What would you say have been the biggest challenges during the last 3 years? Because there's been lots of ups and downs, hasn't there, really?
I think in a funny way, just going full circle, the relationship with the health secretaries have been a real challenge. So I've been through 3 health secretaries in the 3 years. Stephen Barclay just didn't want to know us. We tried again and again to get a meeting with him, never succeeded. I would go up to him at other meetings, bigger meetings, so he knew who I was, introduce myself yet again, say how much we wanted to meet. He was always very polite. He always said, oh, yes, of course we will, and then nothing would come of it. So that was a complete failure, really. Victoria Atkins, she did meet with us. She did appear to listen. I don't think she was there for long enough to do much, and not much happened. And then, of course, as I was saying, this really interesting developing relationship with Wes Streeting. In fact, I have pointed out to him, slightly tongue-in-cheek, that he's performed a shift of his own from really hating our manifesto to adopting 5 of the 7 steps.
I'm sure he appreciated that.
He smiled, but maybe he didn't smile internally. I don't know. I felt it had to be said.
Definitely. One of the big things that's kind of happened while you've been chair of the college is the whole issue around physician associates and how they're being used in the NHS. That became very high profile. It became a big concern for a lot of your members. So that must have been quite a difficult situation to navigate. What were some of the key challenges with that?
That was a terrible situation, actually, because I think, the anger was such that people relieved their anger on social media in a way that was really horrible and very personal. Somebody had gone digging into my past, realised that as an academic medical educator, I'd been at the University of Surrey, setting up a new medical school, and while I was there, my employers asked me to write a curriculum for physician associates. I actually knew nothing about them to begin with, so it was a steep learning curve, and it did seem to me like a good stepping stone to a university that previously just didn't train medics at all. We got it accredited, and then after that I left it to other people to run. That was back in 2017, and in 2023 people dig it up and say, she's a traitor and how dare she do this? And I thought that was just so unkind and so unfair. I was just doing the job I was being paid to do. And at that point, back in 2017, I don't think there had been that much antagonism towards physician assistants, as they're now called, as there is now. Obviously, things changed quite dramatically. And do I regret doing that? No, of course I don't. It was absolutely the right thing to do at the time. But it has come back and hit me really hard. And, it does take a personal toll when you have day after day of unpleasant trolling on it. It's really horrible. Now, when it comes to the college's position, we did have a position that we thought, subject to red lines, which were some very strict red lines, about supervision and about not taking the role of doctors, we felt that they did have an enabling role in general practice. But again, the anger and the frustration from a medical profession who felt it wasn't being listened to became such that at a council meeting about a year ago, we had to really look at it again. And when 2/3 of council voted to say that physician assistants had no role in general practice, that's what we have to go with democratically, whether it seems possible or not. Of course, I think that in a strange way, it had a very interesting effect because nobody had quite come out as didactically as that before. It's felt very bold to say that. Even the BMA hadn't said that. And I think it triggered the Academy of Medical Royal College's letter to the Secretary of State asking for a national review, which then led to the Leng Review, which has, of course, just been published. And we have yet to see how that story finally ends because there's sort of legal matters still to attend to. But those 18 recommendations, they really endorsed the work of the RCGP. We'd spent most of the summer of 2024 writing 3 papers on induction, supervision and scope of role for PAs. That was at a time when we thought they still had an enabling role in general practice. And of course, 2 months later, we'd voted that they had no role. But having said that, there were still 2,000 PAs working in general practice, and there had to be some kind of guidance for those people who were working in general practice, and that's really what these papers did. The Leng Review has looked through our papers and has endorsed them pretty well. I think they feel that my supervision paper is perhaps too stringent, but I still think it's necessary at this stage until the other recommendations are implemented. Whether or not PAs will ever have a role in general practice, I don't know. Quite honestly, I think, with the current pay scales, probably they're too expensive anyway. Even if they do have usefulness in general practice, we'll have to see how things pan out and what happens with the judicial review.
What do you think the NHS and the government needs to learn from what's happened with physician associates? How can we ensure that new roles are introduced to the NHS safely and with the support of other professions in future? Because that's been the real sticking point here, isn't it? It's not necessarily have the buy-in of other professions.
They have a lot to learn, don't they?
Yeah.
I think sadly they didn't listen and they didn't look ahead. They were trying to do good by allowing them in through the R's system back in 2019. I think that was at a time when there really was a shortage of GPs. People were crying out for help, and that was the best and quickest help that they felt they could give at the time. It probably wasn't the best help, and what we really need is more GPs. And they sort of did it with good intentions, but oh boy, has it backfired. It's gone on and on and on. And I think it took our vote from a Royal College to say there's no role, stop this, to make them stop and listen. So I think that learning to listen, not being carried away with trying to promote a role that clearly has problems. I remember being at an NHSE meeting where I was being told about a career structure for PAs. 4 tiers were being suggested. This is NHS England. And the topmost tier, so the most experienced one, would be called a principal in physician assistants. And I, of course, it's almost like a knee-jerk reaction, said, you can't call them that. GPs are principals. That will just add to the confusion. And I was told, don't be ridiculous. Lots of other people are called principals. Why can't they be called principals? And I said, look, I warn you, there's going to be World War III if you do that. It's the only time I've actually shook my finger at somebody on a Teams meeting. And I was told, oh, all right then. Well, what would you call them? And I said, no, that's your job. But I'm warning you that if you persist in this, there's going to be real trouble. And of course there was.
You've talked about your meetings with the various secretaries of state you've had while you've been chair. What have you been really talking to Wes Streeting about in the past 6 months? What have you been really pushing for to happen for general practice?
So we've been particularly talking about, for many months, about the importance of retention strategies, which is another area where the government has been really hesitant to listen to, which I find extraordinary. Interestingly, I was talking to Jo Lenihan, who's writing the new workforce plan, and she mentioned the leaky bucket, which I took as my cue to get back in again on retention, because it's all very well training more and more GPs, but if they're leaving as fast as they're coming in, we're never going to increase the numbers. I've been talking as well about the partnership model and about variations on the partnership model. I'm quite worried as to what's going to happen in the future because many of our younger GPs feel it is too risky to enter into partnerships. They want to work in a partnership, but they don't want to be a partner. And I think that that's going to eventually be a real problem for us. And there are variations of the model that would allow less financial risk, certainly. but it's not easy and most people don't know about them. So we've got a paper that came out a few months back that talks about these variations. Of course, the last 6 months, a lot of it has been spent worrying about what was going to appear in the 10-year health plan. We knew that GPs were going to be centre stage. We knew that they were talking about bringing back the family GP, but we didn't know what they meant by that. As I said earlier, I've been a GP for 37 years. I don't necessarily want to go back to being the family GP that I was 37 years ago, with the weekends on call and the nights on call and the having to visit people. We were obliged. If somebody asked for a house call, you had to go. I'd have 5 or 6 visits every day, home visits, in addition to the surgeries that I did. And of course, general practice has changed. So I would want to be the 21st century family GP, not the 20th century family GP. So we were worried as to what was coming. They built a pretty comprehensive brick wall around the little team that was writing the plan. We couldn't get through it, apart from the submissions we made back in January. So in the end, over Easter, I decided to write something that was really based on what we thought, the RCGP thought, should be in the neighbourhood health plan, based on our submission in January, and then try to post it through every chink I could find in that brick wall. Sent it to absolutely everybody, most of whom didn't acknowledge receiving it. And I know that there were an awful lot of last-minute changes, so I'm hoping that it had some impact, but of course you never really know.
What's your view on the final 10-year plan and what it could mean for the future of general practice? Do you think all of this is the right way to go, or is there anything you're really worried about in there?
Lots of things are good.
Yeah.
And a few things that are not so good, I think, quite serious things that are not so good. So the good things first, always good to start with good, isn't it? I think that putting general practice and community health centre stage is it's high time, with all the evidence we have that having great community services really helps the health of the nation. If they really want the nation to be more productive and more healthy, this is the way to go about it. I think that the neighbourhood health services and keeping universal access. And that was really what was worrying me as to what was going on behind the brick wall, that they were maybe planning to do away with universal access and GP registers. But keeping them, I think, is absolutely key, so that everybody's got a GP, everybody's part of a register of a GP practice and can go and see their GP free at the point of care when they need to. And I think 70% of the population can be looked after pretty well at that level. And then about 20 to 30% who have chronic illnesses, sometimes multiple chronic illnesses, quite complex, multi-morbidity, polypharmacy. There's all sorts of complexities that come into that. They may well need care at a team level, with a proper care plan. And so I think this is where neighbourhood health services will come into their own and do things that I'm struggling to do, even in 15-minute consultations in the practice, where if somebody's got 4 or 5 different things wrong with them, they shouldn't be having to go to 4 or 5 different clinics or being visited at home by 4 and 5 different teams. And there's plenty of anecdotes of this happening. You really need to be having one team who you get to know provides continuity. And so I think it is going to be possible, if we can afford it and if we've got the resources, so there's big ifs, to really radically improve the care that we give to patients, particularly the sicker patients in our communities. So that's sort of part of the secondary to primary care shift. Moving outpatient clinics into the community, that's going to be very interesting to see how that one works. But the diagnostic centres, I think that's really important. We have it in Wales, where of course I'm a GP, the rapid diagnostic centres, they're pretty effective for helping diagnose early cancers. And the sickness to prevention shift as well, really, really important. I'm not sure that there was enough detail in the 10-year health plan to make me feel confident that they know what they're doing or how to do it. And one of the things that I thought was completely missing from the prevention chapter, and which I find endemic where I'm working and where probably most of us GPs are working, was that there's really no mention of drug abuse at all. So they were happy to talk about smoking, about alcohol, about weight reduction, etc., but just nothing about drugs. And I do think that that is just such a massive problem. It leaches out into criminal behaviour, into sex trafficking, into boundary lines, children. There's a lot there, and it just wasn't mentioned. And I thought that was a massive miss. The analog to digital shift then, Yes, I think that does need to happen, but we need to be really careful as to how it happens. Sometimes the technology goes so fast it runs away, and then suddenly you discover that data is not secure or it's being used in ways it shouldn't be used or being sold or all sorts of things, without people's consent. All of that needs to be thought through really, really carefully if we're going to run neighbourhood health schemes in the way that the government is suggesting, and which I think is right. Then we're going to need to have secure ways of sharing patient data, because unless you've got a unified patient record, you can't do the other shifts. Providing GPs with indemnity for data sharing, that's another thing that's going to be really necessary, and which I've been banging on about to the government as well. There are huge potentials actually in AI and IT technology, in genomics. Maybe they got a bit too excited about it in the 10-year health plan, because they certainly seem to major on it quite a lot, when some of the more basic things need to be done first. We all need computers that we can switch on in the morning and rely on to print the prescriptions. A number of times that's happened to me, and I can't print a fit note, but I can print a prescription, and I can't work out why I can print one and not the other. But I think, the possibilities are massive. If you're thinking about wearables and data technology, we should be able to do so much more for people that will keep them at home for longer. That's very exciting. Genomics, very exciting. Pharmacogenomics, really exciting. We can see it coming in, for example, the prescribing of clopidogrel, which is used for prevention of stroke and heart disease. It's used a lot, but about 25 to 30% of our population don't respond to it. But we need to know who they are, and we can do now through genomics. And there'll be other drugs. We'll be able to pick the correct antidepressant for somebody, for example. Most of us GPs go around the houses trying one after another. But it would be so much better if you could just go straight to the one that you know is going to help that person the most. There's great excitement and things coming, but there are also some real worries. I do worry about the GP partnership model and whether or not we're actually going to be able to preserve it. The government is saying that it's not against the model and would want it to continue in places where it's thriving, but I'm not seeing them do much to help it thrive.
Can I just ask you why you think the partnership model is so important? Because I think it is quite useful to sum that up.
There's various aspects to it. There's, of course, the partnership holds a patient register, and keeping a register of patients that you can search on and you can get to know, you can offer continuity of care to, is really, really important, rather than people just being able to go wherever they want to go and 1 minute go and see one doctor and next minute go and see another who doesn't know them, and this sort of thing. So that's very important. The partnership model itself is effective because it's incredibly cost efficient. I mean, the government are crazy not to want to keep the model going. It cannot run into deficit because of the independent contractor status. None of us want to become bankrupt, so we don't allow it to go into deficit, unlike hospitals and trusts and God knows what, who go into deficits of millions of pounds. So getting rid of the partnership model, you've got to be careful what you wish for, really. Having worked in partnerships, I've now worked in 5, I'm afraid. So I've seen the good, the bad and the ugly. And the good partnerships are fantastic. They're an extension of my family when I'm working with them. And in fact, I stay in touch with those doctors long after I've left them. So, it's a special personal happiness, as well as the professional happiness and satisfaction of giving a better service to patients that the model offers.
Obviously, the 10-year plan puts forward these ideas for these new contracts, which they've said could be an alternative to the partnership model. Are you a bit concerned that maybe, these new shiny things, everybody's going to be wanting to throw loads of effort, make sure they're a success? No one's going to want those new kind of contracts to fail. Are you worried that that's kind of a threat in itself? If everybody's focused on making those new things a success, they're not really paying attention to the thing that's propped up the whole NHS since it started, basically, which is local general practice.
I think it depends on what you mean by everybody. Maybe you mean that government and NHSE are going to throw money at that and not at the GP contract. And yes, I am concerned about that. And I think that's crossed most of our minds.
Yeah.
I don't really see why the neighbourhood contract has to be different from the partnership contract. I can't see why the partnership contracts can't be embedded within the neighbourhood contract so that they stay, they remain, they're enhanced. And then there's a neighbourhood contract that envelops it, that is extra. and does those extra bits that I was talking about, that adds the value and enables people to look at the NHS and think, oh, wow, they've moved up an absolute step with this new 10-year health plan. But making it a separate contract, it seems to me to be a bit divisive, because people are now feeling it's either or rather than and. And it should be an and rather than an either or, I think.
You've talked about the workforce plan. You've been quite critical of the current workforce plan we've got, and we know the Department of Health is re-looking at all of that now. From the college's point of view, what do you want to see in that new workforce plan?
It's fairly straightforward. We want some numbers, and we want numbers that make sense as opposed to the last one. Where we learnt that if you really look through them carefully, we'd increase by 4% and hospital doctors would increase by 49%. Well, that's not going to work with a 10-year health plan. So we need numbers that tally and correspond with the 10-year health plan. I'm not sure that we're going to get numbers. I hope we are. We, of course, want to see numbers of GPs rising. And it is definitely clear that they're planning to train more and more GPs. They are coming round to the idea of retention, but they don't seem to be really getting their teeth into it. So I'd like to see some really strong support for retention. And of course, what I'd really love is for them to finally allow us to help them do it. This whole business of being a Royal College influencer means that I have numerous meetings with them. We talk the same ground again and again. They're very polite. They smile very nicely. They go away. And sometimes some of your ideas reappear, but they're usually transmogrified into something that you'd rather not do. They don't really allow us to work with them. I'd like to be able to sit down with them and say, okay, let's have a task and finish group on a new to practice fellowship scheme. Let's have a task and finish group on a late career scheme. Let's do it. This is what we would like to do with you. But that's never happened so far. I'd love to see that.
The college was one of a number of organisations that recently signed a letter that called on the government for more talks and more stakeholder engagement in how that workforce plan was being developed.
Yeah.
Do you feel like the government has not engaged with the professions enough? I mean, not just general practice, but all the other professions as well.
Well, certainly the other medical Royal Colleges feel that way as well when I go to the academy meetings. I think we may be the first of the colleges to have had a meeting with Joe Lenihan, and that was only a couple of days ago. And we've been sort of told that we're privileged to be there. So I don't know really how much engagement there really is. I think they are going to be asking for submissions, so we'll all be doing it in the old-fashioned way of written things that go in. And I know that they get read, and I'm sure they get thought about. But it's different to me. Engagement is a different thing, really. It's not just sending in a written submission. So I'd really like to see that. But then, I'm being told that they're hoping to have it out by the end of the year. That doesn't give much time for engagement, to be honest. And we know that there's a real paucity of district nurses, for example. How are we going to run these neighbourhood health services? We haven't got enough district nurses. I think it's the same thing for health visitors. There are lots of other healthcare professionals who are in just the same boat. I really don't know how our district nurses manage. I really don't. Their workload seems to go up and up. They do more and more. They're so important to the patients they visit. It's just quite extraordinary what they manage. There's no joining up of these things. I mean, one hopes that it's the people who are writing the workforce plan who do the joining up, but it's not being done at my level.
One of the other big topics that's happened over the last couple of years is this horrible situation where all these new GPs are qualifying and they've struggled to get jobs. And it just feels to me like such a failure of workforce planning that we're in this situation. There's lots of problems with doctors in secondary care as well, not being able to get onto specialty training things. And so workforce planning is just so important for making sure that things run properly. So it just seems a bit mad that they're not talking to you about it.
I think there is madness there, isn't there? Or else a conviction that they know the way to do it.
Yeah.
And therefore they don't need us. And I think that it feels slightly insulting, actually, and also a bit frustrating. I think, the last workforce plan was actually the first workforce plan ever, I think. And so we felt lucky there was one until we realised that most of it was rubbish.
Yeah.
And maybe the second one will be better. I hope so.
How has the sort of general landscape changed compared from when you took on the role of chair? What are the big issues, you'll be warning your successor about that may not have been like top of the agenda back when you started 3 years ago?
There's a few things. I think retention and GP numbers thing was just the same then. Obviously, what's happened during my time has been a general election, a change of government, and a new health plan. So, really, for my successor, Victoria, who I think is very much on top of health policy, would be about ensuring that there is a strong GP voice at all levels of the new structures that are coming through. There wasn't a strong GP voice when I came in ICBs, for example. But I think when something's being created again, here's an opportunity to get it in there. And I would also be worried about the partnership model and its future and its health. I'm sure that she'll be keeping a very close eye on that and speaking up for it. We do need to be thinking about the R's scheme and how it all needs to come through the GP core contract now. And lots of people will have their eyes on that R scheme money, I expect, but it really ought to come through general practice. You know, how we influence the development of the plan, because what we've got is very high level. It's still a bit of motherhood and apple pie, and it now needs to be put into practice if it's going to be worth it. And then the whole issue of data sharing has become more and more topical and important. Again, I think Victoria is very much on top of all of these things.
So this year's annual conference is going to be your last as chair. Can you say anything about what you're going to be highlighting, talking about in your speech at all this early?
No, I'm not going to say much about what's going to be in there. There'll be some Welsh, so that'll be fun. And I'm just delighted that it's in Wales for the first time as a Welsh GP. And I hope that it will bring some hope as well, because we've had very little of that over the last few years. I think it is hopeful that general practice is being put centre stage. Stephen Kinnock has twice said to me, GPs will be the conductors of the orchestra. Well, we now need to see that happen. And you can't live on hope. But I hope that I'll be able to put a bit of hope into the speech. I think it's going to be a great conference, and I'm sure it'll be a fantastic buzz, and I hope that conference really enjoys itself.
And what's next for you after you step down as chair? I know you're going on to become chair of the National Academy of Social Prescribing. Why did you want to take on that role? I know one of your predecessors did exactly that move as well, didn't she?
Yes, Helen did that, didn't she?
Yeah.
No, it wasn't just because of Helen, although we've remained in very close contact, almost like a GP partnership. I've always had a very strong feeling that social prescribing gives us some extra tools in the toolbox for all the things that patients come to us about that we really can't treat with medicines. We listen, we can witness, but we can't do much. But we do need a national hub. It can't just be allowed to just go out in a kind of viral way across the country. It'll get fragmented. It'll be done badly in places. It may not be as effective as it could be. So a national academy will be able to set standards, will be able to provide training, will provide peer support, all the things, that this new area, if you like, of the NHS could do with. Its funding, we've been told, is being pulled next year from NHSE. And so one of my biggest jobs is going to be, how do we keep it alive? I don't want to just come in as chair and oversee its demise. But at the moment, it won't have enough funding to survive unless we can pull something out of a hat. That's going to be a worry for me. And in fact, my MD research many, many years ago in the 1990s was using community link workers to deliver health education to raise awareness of diabetes and heart disease in South Asian communities. So I suppose that's a form of social prescribing. So it's gone back many decades in my head, if you like. What else am I doing? I've just been appointed as chair of another trustee board for another thing that I'm very keen on, and that's Pathway. Pathway is a little sibling, if you like, of Crisis, which is the homeless charity. Pathway does the health inclusion work associated with homelessness. And so I'm just taking over as chair of their trustee board, probably from early next year. I'm doing a little bit of work with my old college. I trained in Oxford at Somerville. So I've been made an honorary fellow of Somerville College, and I'm taking on the chairmanship of their Somerville Medics alumni. So that can be quite gentle and great fun to do. And I'm hoping that other things will come along. But at the moment, I think a good rest and probably sleeping through December, probably the first.
You'll still be in the surgery, though, seeing patients?
No, I won't be, actually. I'm retired from clinical practice in June when I turned 65. I thought that that was probably now about right. Been a GP for 37 years. I wanted to go while the going was good. I was enjoying the medicine, enjoying the patients. I think the patients enjoyed me. I love Mountain Ash. So far, because it's only been recent, it just feels as if I'm on holiday. But one day, I think it will really sink in that I've finished with clinical practice and I will be very sad.
I hadn't realised you'd stopped doing that, so that's interesting to know.
It's interesting, isn't it? Most of my contemporaries left years ago.
Yes.
Many of my friends have said to me, Kamila, what are you doing? Why are you still doing all this? And of course I was doing it because I like it. I was enjoying it. And the Mountain Ash community, there's something about them. I wrote a blog a few weeks ago. One of the last things I did was attend a patient's funeral, which was a very Welsh funeral in Mountain Ash. I wrote about it. Yeah, it just feels like it's a part of me.
Just before we finish, you said that you were going to try and bring a bit of hope into the speech at the conference. I mean, a lot of what we've been talking about has been a bit reflective on the last 3 years. And the last decade or so has been really, really challenging. I mean, I have these conversations every year with the chair of the college, and it's always so many challenging issues. What do you feel about the future for general practice? Do you think that general practice has a bright future? And if so, what makes you think that?
I do think it has a bright future if it chooses to take it. We're going to have to be able to think outside the box. We've always done so in the past, and we have risen to challenges in the past. If I were 20 years younger, I'd be really looking forward to this new stage. As it is, as a Welsh GP, I look over the border and think, wow, aren't they lucky? There are such opportunities coming, and I'd be taking them. I've always had an extended role in addition to my core general practice, and I'd be looking for an extended role here within a neighbourhood service. It would depend on what took my fancy or what opportunistically came along. It might be working alongside as the GP component of a drug and alcohol team, if I'm interested in homelessness, or it might be in diabetes because of my previous research, women's health, which is something I've done all my life, or in leadership, because these teams are going to need leading and they're going to need strategic thinking and planning. So it's really exciting what's possible, and really important that the GP voice is heard in all of this and that we get in there. And we need to get in fast. So that's another thing I've been doing in my blogs recently is I've started talking to senior GP leaders across England and asking them for their tips on how do you navigate this new 10-year health plan, putting it into my blogs. I think there is the potential for some really exciting stuff. If you really want to get out there and help your patients and care for them in new ways and be a GP of the 21st century, rather than same old, same old. When I first started in general practice, you had busy morning and evening surgeries. You did 5 or 6 house calls in the middle of the day, and it was that day after day after day. I think it could be very varied and different job now.
All right. Well, thank you so much for your time, Kamila. I really appreciate it. Thank you.
It's a real pleasure, Emma.
Well, that's it for this episode. Thank you for listening, and thanks again to Kamila for taking the time to talk with me. We'll be publishing a special episode from the RCGP annual conference on Friday afternoon, when I'll be speaking to the RCGP Wales Chair, Dr. Rowena Christmas, and other members of the RCGP Council, as well as highlighting some of the key issues from around the event. So keep your eye out for that. You can also catch up with all of our coverage from the RCGP annual conference on our website at GPonline.com/RCGP.